All right, folks, we're going to get started. I have put you all on mute just to eliminate background noise. And if you want to unmute yourself, please do. You can do that by clicking your microphone button, and right now it probably has a red line through it. So thank you for attending. My name is Timothy Byars. I'm the President and Chief Education Officer of Radicle Health, and this is our February Radicle Community webinar. Today we're going to be talking about cannabis pharmacology. So I did want to point out that a lot of times when we're doing our community webinars, this content really is coming out of our curriculum. So if you're a community member and you have not signed up or taken a look at our curriculum, you know, whether you are a clinician treating patients, or if you're working on the retail side in cannabis, or if you're an educator or advocate, what we all need is comprehensive, up-to-date, well-vetted information. And that's what Radicle Health provides in our curriculum. In fact, we've sort of moved the furniture around a little bit. So we have been wanting to provide different access points for students and professionals at different price points. So we've actually restructured our curriculum model. We've made a foundations course. This is this is foundational cannabis information about cannabinoids, an introduction to the ECS, extractions and routes. We've put some of the more complex topics into advanced science and therapeutics. And then for each condition-specific module that we release, we're going to package and sell those separately. So you can see that all three of those are available now. So if you haven't signed up, check them out. You can go to www.radiclehealth.thinkific.com for information, or you can go to our website, www.radiclehealthcare.com, and click one of the education links, and eventually you'll end up at Thinkific. A couple more notes about the curriculum. One, if you're already signed up for the Cannabis Healthcare Professionals course, you might see that it says no longer available. That simply means that we're no longer selling it. Again, we've moved all of those topics into our new course offerings. But you do still have access if you're already signed up, and you'll have access for your one-year term. So nothing has changed there. And the last thing I want to point out is that we are offering for a limited time a lifetime membership. So the lifetime membership, you pay one fee, and you get access to everything that all of our curriculum options and modules that we create in perpetuity. So there is no one-year licensing. You get it from now until you tire of us. And it's every curriculum offering that we produce, you would get access to. You also get access to the Radicle Community. So if you're, for example, if you're paying monthly right now, $9 a month, we would suspend that invoice, and you would just get access to Radicle Community, again, in perpetuity. We're only offering 10 of these. We have a few left, and we're offering them for a limited time. So check it out. Again, you can see that offering at Thinkific, or you can just go to the website and click on one of our education links, and you will find yourself at our curriculum website. So today we're going to be covering cannabis pharmacology, cannabinoid pharmacology. And it's going to be a full hour. We have a lot to cover. I'm going to move pretty quickly. I'll ask that if you have questions, either put them in the chat or save them for later. We will have I'm hoping about 10 minutes at the end for comments and questions for a Q&A session. But we are going to move kind of quickly. We are recording this. Just make sure that we're recording this. Okay, and we're going to add this to the on-demand video library. So if you're a community member, you can always go back and review. So with that said, I'd like to get started. So pharmacology, cannabis pharmacology. Pharmacology is the study of drug properties and their interactions with living organisms and with viruses. And pharmacology typically has subdisciplines as well. So when we talk about pharmacology, it's going to include pharmacodynamics. So this is the study of biochemical, physiologic, and molecular effects of drugs on the body. So this is a discipline that's going to study things like receptor binding and affinity, post-receptor effects, chemical interactions. Pharmacodynamics is often described as what a drug does to the body. We're going to talk a lot about these concepts today. This is mostly where we're going to be focusing, is in pharmacodynamics. Pharmacokinetics refers to the movement of a drug into, throughout, and out of the body. It measures and describes the absorption, metabolism, distribution, and excretion of a drug. Pharmacokinetics is sometimes described as what a body does to the drug. We're going to spend less time on this today. We actually have maybe 1 or 2 slides toward the end where we're going to talk about excretion. And then there's pharmacogenetics. This is a really exciting field. It's a bit newer. This is the study of genetic differences that affect individual responses to a drug. So these are genetic differences. They can be individual differences specific to enzymes, drug messengers, receptors, metabolic pathways, and they can really impact therapeutic effects and also adverse effects experienced by individual patients. So we're going to talk a little bit. We have a few slides at the end where we'll talk about pharmacogenetics. This is kind of an overview of what these concepts look like. So in the far left, in the top green box, it says drug release and dissolution. So this is your route of administration. It gets absorbed into the body. Once that absorption occurs, that drug goes into systemic circulation and then gets distributed into drug tissue. Once it gets distributed into body tissue, and once that drug gets distributed into the tissue, that's where you experience pharmacodynamic effects. You have compounds in that drug that are binding with receptors and initiating processes. And then, of course, once a drug is in systemic circulation, the body begins to metabolize it and also begins to excrete it. So the first thing that we're going to talk about today are receptors. And receptors are proteins. These are proteins that are made up of amino acid chains, and they initiate cell changes well, they're responsible for initiating changes in cells. So the human body contains over 37 trillion cells, and each cell has a specific function. It has a task or set of tasks that it's responsible for performing. And to perform these tasks, the cells have to have mechanisms for communicating with substances that are outside of the membrane of the cell. And this is where receptors come in. So receptors are embedded into the cell membrane, and they facilitate changes that occur inside the cell. So when stimulated by the right kind of substance, a receptor can initiate a variety of processes inside the cell. Now, the discovery of the first cannabinoid receptor was made by Alan Howlett and her associate William Devane. This was in 1988, and once they discovered the first cannabinoid receptor, researchers then started to assume that there must be some substance that the body naturally makes, some natural ligand that the body makes that will naturally bind to this receptor. And of course, the first endogenous cannabinoid was discovered by our friend Dr. Mechoulam in 1992, again in association with William Devane, but also with Dr. Lumir Haynes. Now, we're not going to talk a whole lot about endogenous cannabinoids today, but just as a reminder, the two most studied and well understood endogenous cannabinoids are anandamide and 2-arachidinyl glycerol, or 2-AG, and they're metabolized by enzymes, and those enzymes are fatty acid amide hydrolase, we're going to call it Pha, and also monoacylglycyl lipase. And we're going to talk a little bit more about Pha later. Before I move off of this slide, I do want to just mention, talk a little bit about a term, G-protein coupled receptor. So cannabinoid receptors and many of the receptors that we're going to talk about today are G-protein coupled receptors. They have a couple of different distinguishing attributes. So the first one is that they actually penetrate the cell membrane 7 times. And so they kind of wind in and out of the cell membrane 7 times. And the second unique attribute about them is that when substances bind to them on the outside of the cell membrane, they send signals through the protein, through the amino acid chain, and those signals are sent to another protein that's attached to that cell receptor on the inside of the cell. And that's actually a G protein. That's why this receptor is called a G protein coupled receptor. So it's the G protein on the inside of the cell that's actually initiating the changes. So we're going to talk a lot about ligands today. And a ligand is simply a molecule that produces a signal by binding to a site on a target protein, by binding to a receptor. So when cannabinoids, for example, when they bind to G protein coupled receptors like CB1 and CB2, they're acting as ligands. This is a pretty simple, obviously, it's a pretty simple illustration of ligand binding to a receptor, but you can see that part of the receptor is on the inside of the cell, part of the receptor is on the outside of the cell. That binding site has a specific shape, and the ligand has a similar shape, and the ligand's going to fit into that receptor, and it's going to initiate some changes inside the cell. Often we see an analogy of a lock and key that's being used, and that's fine, but it really isn't sufficient to describe the complexity and nuances of ligand and receptor binding. But it is sufficient to describe the type of interaction that's occurring. So cell membranes are comprised of different receptor types, and each type is designed for a specific set of messenger molecules, and each distinctly influences the activity of the cell. So receptors have a couple of different binding types. They have a main binding site, they have an orthosteric binding site, and they also have a secondary binding site called an allosteric binding site. And there are specific types of ligands that can bind to each one. And we're going to go through and talk about each one. But you can see on the left-hand side, there are 4 ligand types, general types that bind to orthosteric sites. And on the right-hand side, you can see that there are 2 general types of ligands that bind to the allosteric site. And then you can see that we have kind of a generic G protein coupled receptor that is moving in and out of the phospholipid bilayer. And I just want to note about this illustration before I move on that I have kind of identified 2 places on the G protein coupled receptor where the orthosteric site is and the allosteric site is. Don't mistake this for specificity. I'm just identifying 2 random places in this illustration where there might be binding sites. And there are these types of binding sites throughout the protein. So the types of ligand binding types that bind to the orthosteric site, the first one is a full agonist. So full agonist will activate a receptor to the fullest extent possible. So if you have watched or if you attended our January Radicle Community webinar, you know that many synthetic cannabinoids, HU210, JWH18, they are full agonists at the CB1 receptor. At CB1, full agonists are not necessarily desirable because of the frequency of side effects and the severity of adverse side effects. The second type of ligand that will bind to an orthosteric or to the main binding site are partial agonists. Partial agonists activate the receptor, but they do not activate it to the full capacity. THC, for example, at CB1 is a partial agonist. So one interesting thing about partial agonists and full agonists is that they actually compete for the same binding site. So if you have somebody who is having a very adverse side effect to a synthetic cannabinoid, theoretically, you could give them some THC and their condition might improve. The third type is a neutral antagonist. So neutral antagonists bind to the main binding site, to the orthosteric site, but they don't actually influence the receptor at all. So there's no signaling that occurs when a neutral antagonist binds to that site. What they do is they prevent agonists from binding to that site. So they're called neutral antagonists because they inhibit receptor activation. So if agonists can't bind to the main site and stimulate activation, then you're inhibiting that activation at that specific receptor. So a couple of examples of what neutral antagonists are. CBD at very high dosages and can very weakly bind to CB1. And so this is sort of an example of a neutral antagonist. It will bind to CB1 as a neutral antagonist. But a better example is Narcan, which is the brand name of a generic opioid called naloxone. So naloxone is given to people who are having an overdose on opioids. And naloxone is actually an antagonist at the mu opioid receptor. And so what happens when somebody is having an overdose on opioids is that they have very high concentrations of opioids at the mu opioid receptor. So a paramedic or a clinician will inject very high concentrations of an opioid antagonist like naloxone, and it has such binding affinity at that receptor that it knocks all of the opioids, displaces all of the existing opioids off that receptor site, and it essentially reverses the condition of that patient. So that's a pretty good example of a neutral antagonist. So the fourth type, the last type of ligand type that binds at the main binding site is an inverse agonist. All G protein coupled receptors have what's called constitutive activity. So this means that they have a baseline level of signaling even in the absence of an agonist or a partial agonist. An inverse agonist not only binds and blocks agonist binding, so it binds to the site, but it also inhibits that constitutive activity. Now at CB1, at the CB1 receptor, there has been a prescription medication that was developed as an inverse agonist at CB1. It was developed to treat obesity. So recall that CB1 modulation affects appetite. So researchers thought, maybe we can develop, we can inhibit cell signaling at CB1, and maybe that would help people lose weight. It would satiate their hunger pains. It would make them, it would suppress their appetite. It was released in 2006 in Europe. It was recalled in 2008 for severe depression and suicidality. So what they found is that not only does it control appetite, but it also controls mood. So it's a good example of how these receptors, especially cannabinoid receptors, they're not binary, they're not simplistic. You can't simply turn it off and get one effect and turn it on and get some other effect. They're more complex and they're more nuanced. So there are two ligand types that bind to the secondary binding site, to the allosteric binding site. The first one is called a positive allosteric modulator. These bind to the allosteric site. They amplify the effect of an agonist by increasing agonist binding or by increasing receptor signaling. So one thing that's important to note that anything that's binding to the secondary site has no effect on a cell receptor unless something is also binding to the main orthosteric site. So for example, CBD is a negative allosteric modulator. We haven't talked about that. We'll talk about that next. But CBD is a negative allosteric modulator at CB1, has no effect on CB1 unless THC is binding at the orthosteric site. Anandamide, THC, CBD, these are all positive allosteric modulators at glycine receptors, and we'll talk a little bit about glycine receptors later. And of course, the second type is at the allosteric site is negative allosteric modulators. These decrease agonist binding and they decrease receptor signaling. So again, CBD at CB1 is binding to the allosteric site as a negative allosteric modulator, and it's mitigating the effects of THC. Now, some of those effects are considered adverse, lethargy, for example, or psychoactivity. So back to our illustration, you can see now that I've replaced the orthosteric site with the THC. This would be an example of binding at CB1 at the CB1 receptor. So we can see that THC is binding at the orthosteric site as a partial agonist. Our G protein coupled receptor again is CB1, and then CBD is binding at the allosteric site as a negative allosteric modulator, and it's inhibiting the effects of THC. Some of this may seem somewhat arcane, and you might be thinking, why do I need to know about ligand binding types? But it's actually kind of critical if you're to understand how cannabinoids work in the body. Because the way that cannabinoids work in the body is they have a specific therapeutic effect depending on what receptor they bind with and how they bind to that receptor. So This is a chart that is we've pulled directly out of our curriculum. So if you're a curriculum member, you can go in and use this as a reference. But at the very least, learning how cannabinoids bind at the cannabinoid receptors can be really instructive, and depending on what you do in the cannabis space, might actually help you understand how these cannabinoids are going to affect change in the body. So one example is if you look across the row at CB1, you can see that there are two negative allosteric modulators listed, CBG and CBD. Well, what do those two things have in common? Well, we know that both of them might be effective at treating anxiety. Maybe inhibiting activity at CB1 is something that can help with anxiety. A couple of other interesting things to point out on this chart. THCA is listed as a weak partial agonist at CB1. Some of the research does demonstrate that it is a very weak partial agonist. However, THCA has very little affinity at either CB1 or CB2, and we think that it might be demonstrating weak partial agonist attributes, because when you work with THCA or any of the acidic cannabinoids, they're so volatile that they start to convert. So it might actually be that the THCA in some of these studies started to convert, and that's why it's showing up as an agonist. The other interesting thing to point out here is that THCV is listed. It's the only antagonist. It's the only cannabinoid that's an antagonist at CB1. Now we know CB1 activity is responsible for psychoactivity. And we also know that THCV occasionally can demonstrate psychoactivity. When some people report psychoactivity when they use THCV. How is it that if you have an antagonist at CB1, something that's inhibiting CB1 signaling, it can produce psychoactivity? The answer is because it's dose dependent. So at very low doses, we find that THCV can be an antagonist at CB1, and at very high doses, THCV can be an agonist. It can stimulate CB1 activity and produce psychoactive results. So we're going to talk now about some specific receptors, and we're going to start with the cannabinoid receptors. So we know that when cannabis is consumed, the phytocannabinoids that are produced by the plant, they bind to receptor sites throughout the body. Cannabinoid receptors, CB1 and CB2, are both G protein coupled receptors. They're located in the brain and the organs and the connective tissues, the glands, the immune cells. We also know that there are multiple receptors modulated in the endocannabinoid system, but the ones that are very well studied with respect to cannabis are CB1 and CB2. We're going to talk about some other ones today, but we're going to start with these two. Now again, it's important to remember that the effect of a cannabinoid depends on the receptor to which it binds. So for example, THC, when it binds to CB1 receptors in the brain, produces a psychoactive effect. But when THC binds to CB2 receptors throughout the body, it can produce an anti-inflammatory effect. Specific cannabinoids produce unique therapeutic effects depending on the receptor cell to which they bind and the manner in which they bind. So whether that's a negative allosteric modulator, partial agonist, neutral antagonist, etc. So let's start with CB1. CB1 receptors, again, G protein coupled receptors, located mostly in the central and peripheral nervous system, but also in the immune system, so in the bone marrow, thymus, spleen, tonsils, also in the heart, lungs, adrenals, kidneys, liver, colon, prostate, pancreas, testes, ovaries, placenta. Widespread in the human body. In the brain, CB1 receptors are concentrated in areas associated with the behaviors that those receptors influence. So for example, CB1 receptors help regulate appetite, and those are through receptors that are found, CB1 receptors that are found in the hypothalamus. CB1 receptors can influence memory and emotional processing. These are through receptors in the amygdala. And they also mediate sensation to pain. And of course, these are through CB1 receptors that are found at nerve endings. CB1 receptors are activated by phytocannabinoids, by cannabinoids found in cannabis, by our endocannabinoids, anandamide and 2-AG, and also by synthetic cannabinoids. And of course, the activation of CB1 receptors is responsible for the psychoactivity that we feel when we use THC. The THC metabolite, we'll talk a little bit more about metabolites later, 11-hydroxy-THC, interacts more efficiently at CB1 than THC does. And even though these CB1 receptors are very widespread, there are very few of them in the brainstem, and there are very few of them in the cardiorespiratory center. And that's why we don't have a lethal dose of cannabis. CB1 receptor activation helps mediate anxiety and stress, pain and inflammation, symptoms related to MS, neurodegenerative disorders, post-traumatic stress, depression, intestinal inflammation, blood pressure. I should also note that there's still research that's going on with receptor antagonists and inverse agonists. So these are all therapeutic benefits when you activate CB1 receptors, but there can also be therapeutic benefits when you inhibit CB1 receptors. So even though rimonabant is no longer on the market for medication, it's still used in research communities because they want to try to test these inverse agonists at CB1 to see if they can treat things like obesity and liver fibrosis and nicotine addiction, because we do have patients who have unusually raised levels of endocannabinoids, and we need to bring those down back into a healthy level. So that research continues as well. And then we have CB2. These are also G protein coupled receptors. They're located in the brain and the peripheral nervous system, but they're concentrated in the peripheral immune system. So bone marrow, thymus, spleen, tonsils. But they're also located in the uterus, they're located in the lungs, they're located in the microglia in the brain. The number of available of CB2 receptors increases significantly during inflammation. So these are actually made on demand. And of course, we know that CB2 receptor activation it does not produce psychoactivity that's associated with CB1 activation. CB2 receptor activation helps mediate inflammation, neuroprotection, especially in cases of Alzheimer's, Parkinson's, Huntington's, and MS, addiction and drug-seeking behaviors, depression, bipolar, schizophrenia, alcoholism, and eating disorders. I want to talk just briefly about beta-caryophyllene. Beta-caryophyllene, of course, is a common terpene that's found in cannabis. Unlike other terpenes, however, beta-caryophyllene, or BCP, it exhibits ligand-like properties. It's actually an agonist at the CB2 receptor, and it's demonstrated affinity with other receptors that influence neuropathic pain and also anti-addictive behaviors. So BCP, because it's an agonist at CB2, it demonstrates potent antioxidant, anti-inflammatory properties. It's an antispasmodic. It's an antidepressant, anxiolytic, and again has anti-addictive properties. Because it activates the CB2 receptor and has therapeutic effects that are similar to cannabinoids, there are some researchers who are suggesting that it should really be reclassified as a cannabinoid rather than a terpene. In fact, in one study, BCP as an anti-inflammatory was more effective than many synthetic cannabinoids. So those are the two main cannabinoid receptors. So now we're going to talk about some other receptors that are also modulated by the endocannabinoid system. And the first one we're going to talk about is GPR55. GPR55 used to be known as an orphan receptor. What this means is that researchers discovered the receptor before they understood what the natural ligand was. They found the receptor, but they didn't know what it was for and what was binding to it. GPR55 receptor activation has been associated with cancer cell proliferation and disease progression, also inflammation and certain types of pain. So in one study, there were mice that were genetically bred without GPR55 cell receptors, and these mice demonstrated lower levels of inflammation, induced pain, and lower levels of neuropathic pain after nerve constriction. So CBD is an antagonist at GPR55. So by inhibiting activation of GPR55, we think that CBD might reduce seizures by blocking activation of this receptor in the hippocampus. CBD might produce anti-tumor effects in colorectal cancer, breast cancer, pancreatic cancer, and brain cancer. And CBD might reduce gastrointestinal inflammation in conditions like IBD, Crohn's disease, and ulcerative colitis. Again, because it's an antagonist at GPR55, and we know that GPR55 activation is responsible for, again, cancer proliferation, inflammation, and pain. Then we have 5-HT receptors. These are mostly G protein coupled receptors. They're typically activated by the neurotransmitter serotonin. So 5-HT is an abbreviation for 5-hydroxytryptamine. Collectively, these are referred to as serotonin receptors. And 5-HT receptors influence aggression, anxiety, appetite, cognition, learning, memory, mood, nausea, sleep, and thermoregulation. It's a very important family of receptors. These receptors are the targets of hallucinogenics and also many prescription medications, antidepressants, antipsychotics, anti-migraine, antiemetics. There are 7 distinct families of 5-HT receptors, and most of those families have multiple subfamilies. We're just going to talk about 2 today. And the first one is 5-HT1A. So these receptors are one of the 5 subtypes of 5-HT1 family receptors. They're the most widespread of all serotonin receptors. These are located in high densities in the central nervous system. 5-HT1A receptor activation can decrease blood pressure, can decrease heart rate and body temperature. Also, 5-HT1A receptor agonists can help relieve anxiety, depression, nausea, and pain. 5-HT1A receptor activation might also improve symptoms related to schizophrenia and Parkinson's. We have research in animal models that suggests that CBD activation of 5-HT1A receptors might help mitigate liver damage, anxiety, depression, pain, and nausea. CBD is a full agonist at this receptor, so that's why we think it might actually help with these conditions. We have 5-HT3 receptors. These are ionotropic receptors. They're structurally distinct from the other 5-HT family receptors. So activation of 5-HT3 receptors is associated with nausea and vomiting, seizures, pain, and mood disorders. So I want to talk just briefly about ionotropic receptors without getting too much into the chemistry. These are structurally distinct from G protein coupled receptors. The G protein coupled receptors are also called metabotropic receptors. So you have metabotropic and ionotropic. They're 2 main categories of receptors. Binding at ionotropic receptors causes channels to open up. They physically open up in the cell wall. So unlike G protein coupled receptors where there's just a signal that's sent, there's actually a channel that opens up, ions flow into the cell, and these ions are what's responsible for causing the action potential to initiate cell changes. THC and CBD are both potent negative allosteric modulators of 5-HT3A receptors. We know that 5-HT3A antagonists can help treat chemotherapy-induced nausea and vomiting, and that's why we think that THC and CBD are helpful in both of those conditions. Interesting thing about this receptor, alcohol is a positive allosteric modulator of 5-HT3A receptors. So if you've drank too much alcohol and you wake up the next morning, it's probably because your 5-HT3A receptors are firing frequently and alcohol is helping them fire. So you might want to consider taking a 5-HT3A antagonist or negative allosteric modulator. In other words, use some cannabis. Dopamine receptor D2. This is a subtype of one of the 2 main families of dopamine receptors. This is a receptor that's often just called D2R. These are protein-coupled receptors. They act as the primary target for most antipsychotic drugs. Drugs acting At D2R are commonly used to alleviate symptoms associated with Parkinson's disease, schizophrenia, and depression. Antipsychotics are often prescribed for these diseases because they're potent partial agonists at D2R, and they increase dopamine signaling. CBD is also a potent partial agonist at D2R, and it might be one reason why CBD is helpful in these kinds of conditions. It's interesting that D2R agonists, though, they do produce adverse effects. Those adverse effects include GI distress, like abdominal pain and diarrhea, dizziness, headache, and fatigue. We know that at high dosages, CBD can also produce some of these same effects, and this might be the mechanism through which those adverse effects are felt when you take high doses of CBD. Adenosine receptors. So these are G protein coupled receptors. They're typically activated by adenosine. Adenosine activation causes drowsiness and memory impairment. And what is the most common adenosine receptor antagonist? Of course, it's caffeine. It's what we use every morning to make sure that we're not drowsy and that we have sharper memories. Caffeine inhibits adenosine signaling, and this in turn produces stimulating effects. THC and CBD do not actually bind to adenosine receptors, but they do influence adenosine receptor signaling, and they do that by inhibiting adenosine signaling uptake. So when neurotransmitters are released in the body, there's a cell that releases them into the body. They go off, they do their thing. They're usually pretty short-lived. The body will either have some kind of enzyme that metabolizes those neurotransmitters, or the cell that released them will actually bring them back into the cell. That's called uptake. And there are certain things that facilitate, drug transporters that facilitate the uptake back into the cell. So what CBD and THC both do is they competitively bind to those drug transporters so that the adenosine isn't able to get taken back up into that releasing cell. So that's why THC and CBD can influence adenosine signaling. It actually induces adenosine signaling, and maybe this is why THC and high doses of CBD sometimes can cause fatigue. We also know that adenosine agonists have anti-inflammatory effects, and adenosine uptake is the primary mechanism for the termination of adenosine signaling. So there's not really a whole lot of metabolism that happens with adenosine. Really, it's just it gets brought back up into the cell, and that's how the signaling terminates. So it's well established that cannabinoids also have anti-inflammatory effects, and we know that most of those anti-inflammatory effects are mediated through CB2 signaling. CBD, again, doesn't really bind to CB1 or CB2. By facilitating adenosine signaling, we have a non-cannabinoid receptor mechanism through which CBD produces anti-inflammatory effects. You know, CBD does a lot of stuff. THC and CBD are really therapeutic. They have a lot of therapeutic effects, and a lot of those effects with respect to THC are mediated through the cannabinoid receptors, but with CBD, it doesn't really bind to either one of those receptors. So we have to start looking for non-cannabinoid receptor mechanisms through which CBD works its magic, and this is one of them. So this is a non-cannabinoid binding mechanism through which CBD can have its therapeutic effects. So there is some debate about whether high doses of CBD can be sedating. In clinical trials for Epidiolex, sedation was one of the most common side effects. This effect might be related to amplified adenosine signaling. Again, CBD facilitates adenosine signaling and might contribute to fatigue. There are some people in the medical cannabis space, very prominent people, who will argue that CBD, even in its pure form and even at high doses, is not a sedative. Dr. Rousseau, for example, will say that the sedative effects that were noted in the Epidiolex clinical trials were really the effect of polypharmacy, where CBD was possibly potentiating the effects of other drugs that produce sedation as a side effect. Dr. Rousseau will point to products that have high dosages of CBD, if they're sedating, he might suggest that that's really the effect of the terpenes that are also in those products, things like linalool or myrcene. I did directly ask Dr. Rousseau what he thought about CBD facilitating adenosine signaling, but he wasn't able to get back to me. So it remains a topic of research. So if any of you come across an answer, please send us that information. It'd be good to find out how instrumental CBD facilitating adenosine signaling is when contributing to fatigue. Glycine receptors. So we mentioned these earlier. These are also ionotropic receptors. They inhibit nerve activation. Nerve activation regulates pain and inflammation. Anandamide, THC, CBD, these are all positive allosteric modulators of glycine receptors. In one study in mice demonstrated that CBD specifically can potentiate glycine receptors. And this, of course, helps to inhibit transmission of pain signals and can help treat chronic pain. GABA receptors. These are a class of receptors that respond to the neurotransmitter gamma aminobutyric acid, I'll just call it GABA. There are two families of GABA. There's GABA A and GABA B. GABA A receptors are ionotropic receptors. They mediate the effects of barbiturates, benzodiazepines, and also alcohol. GABA A receptor activation can produce anxiolytic effects, anticonvulsant effects, amnesic, sedative, hypnotic, euphoric, and also muscle relaxing effects. CBD is a positive allosteric modulator at GABA A, and this is a mechanism that might help explain why CBD has anti-epileptic and anxiolytic properties. THC can also influence GABA signaling. It inhibits uptake of GABA. CBD does to some extent as well. There's some research from the mid-1970s that suggests that CBG inhibits GABA uptake more efficiently than either THC or CBD. I'm going to do a time check here. All right, we're doing well. We're going to move on to enzymes. Enzymes are also proteins. They're also chains of amino acids. They're very similar to cell receptors, except they have a fundamentally different role to play in the body. So where cell receptors are transmitting signals from outside the cell to inside the cell, enzymes are responsible for catalyzing reactions in the body. So that means that they're accelerating the conversion of one substance, sometimes that's called a natural ligand or a substrate, into another substance, the product of that reaction. So enzymes really are mostly responsible for metabolizing our drugs. They help the body eliminate drugs, and they do that mostly through making chemical compounds more water soluble. Now, natural ligands or substrates, they bind to enzymes using a process called induced fit. And this happens at both orthosteric and allosteric binding sites. So just like cell receptors, enzymes have different types of binding sites as well. So when a ligand begins to bind at an enzyme, the interaction causes the enzyme's active binding site to start to conform more accurately around the shape of the ligand, and that increases the ligand's affinity to the binding site, and it also maximizes the enzyme's ability to catalyze the reaction. So here's an illustration of sort of how this is happening. These gray moon-shaped things are the enzymes, and then the thing on the far left, that's the substrate. So as the substrate starts to bind with the active site, you can see that the active site isn't quite the same shape, but as the binding starts to take shape, the enzyme starts to conform around it. It produces a reaction. It changes the substrate into a different product, and then it releases that product back into the body, and then the enzyme retakes its original shape. So the enzyme is unchanged by the reaction. And again, enzymes have allosteric and orthosteric binding sites. So there are some molecules that can actually inhibit or induce the enzyme activity. So some molecules bind to the allosteric site. They can induce the reaction between a natural ligand and an enzyme. So you can see that on the right here. These molecules cause the enzyme, again, to slightly modify the shape of the main binding site and increase the affinity with the natural ligand, and thereby they increase the reaction rate. So on the right-hand side here, you can see the enzyme, the activator, is binding to the secondary site, and as it does, it helps the active site sort of reshape itself so that it's a closer fit with the ligand, and then you have a better reaction. It induces activity. Other molecules can actually inhibit the enzyme's ability to catalyze reactions. So some molecules simply competitively bind at the active site. So when they bind to the active site, they block natural ligands or other substrates from binding there. Some molecules inhibit enzyme activity by binding to the secondary allosteric site. This is called non-competitive binding. And again, it causes the enzyme to reform the active binding site, but this time in the opposite manner. So you can see on the left-hand side, you have an orange or pinkish molecule binding to the secondary allosteric site, and it causes the main active site to change its shape. But in this time, it's changing its shape, so there's not as good of a fit with the substrate, and so therefore you're decreasing the reaction rate. So here's one thing that is important to remember. When you have enzyme inhibition, so something similar to on the right-hand side, this is going to cause the serum levels of drugs to go up. So if you have enzymes that are responsible for metabolizing drugs and they're not working efficiently because this is what's happening on the left. It's either because there's something else that's blocking that binding site, or it's changing the shape. Less of that drug has been metabolized. More of that drug is available for the body for bioabsorption. More of that drug gets into the bloodstream. So inhibition causes serum levels of the drug to go up. The side effects of that, of course, would be drug toxicity and greater increase of adverse side effects. Enzyme induction, so when you stimulate the metabolism or the reaction rate of an enzyme, causes the serum levels of drugs to go down. So this would be something on the right-hand side. So if you have more enzyme activity, more of that drug is being metabolized, less of that drug is getting into the bloodstream, and so less of it is available for the body to use. The side effects of that, of course, would be that you don't have the expected effects of that drug because less of it got into the bloodstream. Now, THC and CBD molecules are both absorbed in the GI tract, but they're also highly metabolized in the liver. They're metabolized by a family of enzymes called cytochrome P450, and this is a family of enzymes that metabolize drugs. They chemically modify, detoxify, and remove drugs from the body. And again, they do this mostly by making these chemical compounds more water soluble. So in the body, THC is mostly metabolized by the CYP enzymes 2C9 and 3A4. These enzymes convert THC into 11-hydroxy and then eventually into 11-carboxy THC. There is some metabolism of THC that happens outside of the liver, so it occurs in tissues that also express these CYP enzymes. This would be, for example, in the small intestine, but also in the brain. And then it's important to know that some long-term storage of THC occurs in body fat. CBD is mostly metabolized in the liver by CYP enzymes. This would be by CYP 2C19, also by 3A4, and CBD is converted into 7-hydroxy cannabidiol. I want to talk a little bit about Pha, because Pha is an enzyme that's really important in cannabinoid metabolism. Pha metabolizes the endogenous cannabinoid anandamide. And there's some research that suggests that CBD inhibits Pha, and so by doing so, it can subsequently potentiate the effects of anandamide. So if less anandamide is being metabolized because there's less Pha, more of that anandamide is available in the body, and it could stick around longer and have greater impact on the body. There was a really fascinating case study that was reported last year, a woman in Scotland. She had a genetic mutation where she produced very little Fa, if any at all. And when they tested her levels of anandamide, they were kind of off the charts. She had very high levels of anandamide. She had reported that she was immune to anxiety and fear. She didn't know what those emotions felt like. And she was insensitive to pain and had been her entire life. So I want to talk just briefly about pharmacokinetics. Complete elimination of cannabinoid metabolites. This is going to occur over several days. It's through slow rediffusion of cannabinoids from the body fat and other tissues. About 20 to 35% of metabolites from cannabinoids are excreted through urine, 65 to 80 eliminated through feces, about 90% excreted within 5 days. It's really important to remember that residual levels of cannabinoids remain in the body for some time, especially in long-term users. So the half-life for THC for an infrequent user is for infrequent users is 1.3 days, but for frequent users it's 5 to 13 days. So, and also after inhalation, there's a metabolite called carboxy THC that can be detectable in plasma for as long as 1 week. So, for example, when you hear stories about people who were tested for cannabis after an automobile accident, we probably don't know whether they used cannabis that day or a week ago, or if they were a frequent user 3 weeks ago. I want to talk really briefly about pharmacogenetics. I just have a couple of slides, and then we'll take some questions and comments. Pharmacogenetics, again, it's the study of how genetic differences influence enzymes, drug transporters, receptors, and metabolic responses to drugs. Pharmacogenetics might not only contribute to differences in efficacy and adverse effects among different ethnicities and genders, but also differences among all individual patients. So clinicians and patients can use pharmacogenetics as data points for predicting patient response and for mitigating adverse side effects, especially in cannabis-naive patients or in patients who are poor metabolizers. So if a patient has a history of having really crazy sensitive reactions to medications, they can use genetic testing to figure out what's happening in their own body. Genetic variations can determine the strength of a dose, so how much of a cannabinoid is metabolized before the cannabinoid reaches the bloodstream, and also by how much of a cannabinoid crosses the blood-brain barrier, and also the duration of the effect of a dose, so how efficiently your body can eliminate cannabinoids. These are typically called these genetic variations are called polymorphisms. There are several that are relevant to cannabis patients. The primary metabolism for THC, again, occurs through 2C9. There are over 50 polymorphisms of 2C9. The most common version is 1. But patients who have the version 3 have decreased enzyme activity, and so they are more sensitive to cannabis than other people. So if you got your genetic testing back and you saw that you had the polymorphism of number 3 at 2C9, you know that you should probably be starting at a lower dose of THC. The enzyme 3A4, again, this metabolizes about 65% of our prescription medications and a lot of our over-the-counter medications. And it's also involved in THC and CBD metabolism. The variant 22 eliminates cannabinoids less efficiently, and also these patients will experience stronger effects and longer duration of action. Patients with the polymorphism at the gene COMT, this is a gene that encodes for an enzyme that metabolizes dopamine in the brain. These patients might experience more severe side effects from cannabis use, especially related to memory deficit. And then finally, patients with a polymorphism that inhibits the expression of P-glycoprotein drug transporters. These are the drug transporters that carry compounds back up into the cell during uptake. These patients who have this polymorphism have significantly higher risk of cannabis dependence.